Thanks, Natalie. I'm Dr. Shay Moore, but on paper it's Carolyn. So I'm a family medicine physician, prior Air Force. I work at Colorado Physician Partners, and full disclosure, was called a couple hours ago to moderate this talk tonight. So I have to give credit to Dr. McDonald, who I think came up with the actual questions. My name is Lisa Moore. I am a dual boarded headache medicine and general neurology physician, general neurologist. I work at Colorado Springs Neurological Associates and been here for about 2 years. And I've always had an interest in women's health. And I think part of that just comes with my subspecialty. I see a lot of young women, older women, and I have some special interests in family planning as well.
Is this one okay? Loud enough, do you think? Okay. I'm Meredith Cassidy. I am an OBGYN here in Colorado Springs, and I am also prior Air Force. I've been doing this for 20 plus years. Do I have to say the number? Okay. So OBGYN at, excuse me, at the Air Force Academy after residency, and then joined Academy Women's Healthcare. And we sold our practice to Centura, which is now Common Spirit. So I've been in my location for 20 plus years. I do both obstetrics and gynecology. In the past, it kind of used to be as you got older, you got out of the obstetrics and did all gynecology, but most of us, at least in our practice, that is not what we're doing. Partly financial, you need to know that. There's a financial issue with OB is where the money is, but also just interest. I like all of it at this point in time, so yeah.
Thanks. Okay, so we're going to dive right in. Our first question, research shows that physician patients tend to have better care experiences, but also tend to delay seeking care. We self-diagnose and we skip follow-ups. As women physicians, have you found it harder to be a patient than a doctor? And does gender compound that difficulty?
So I have found it significantly harder to be a patient than to be a doctor. We were just talking about this a little bit earlier. I have a primary care. Have I seen them within the last year? No. Do I need to make an appointment? Yes. It is on my to-do list. I think one trouble that I've had throughout the years personally, I've always had this mantra for myself, I can have it all. I can do it all. I can be it all. And I'm realizing, as time goes on and life gets busier, with no end in sight, that's just not the case. I'm finding that I should, be able to have what's important. So my mantra's kind of changed slightly. But definitely I find that, I care so much for my patients, and I have the tendency to put myself on the back burner. And I don't think that that's uncommon in our role. And I think that a lot of us do recognize that that's not what we should be doing. In some ways, I'm telling my patients, you have to put your oxygen mask on before you can help others. But I also need to listen to that advice. So like I said, it's on my to-do list. And hopefully, hopefully the wait isn't too long to get in for a follow-up.
So I have to confess, I am one of those people that did some of my own OB care during pregnancies and skipped my postpartum appointments. But I will say I do have a really good family history, as in healthy family history. So that's can be an excuse at times, but I do keep up on my yearly visits because Centura used to give us points for that. Now that doesn't happen anymore. So, but I still will do it. yeah, so it is harder to be a patient because you have to schedule things on your day off, at least in my field. And there's many other things I want to do on my day off. So it's harder. Does gender compound that? Potentially, just like what Lisa was saying, because we tend to take care of the rest of the family. So yes, women physicians do tend to take care of more of the rest of the family. So it makes it harder.
So a previously suggested question for this panel stated that female physicians with chronic conditions often have multiple specialists. The counter argument is that a strong primary care physician who coordinates care is actually the most valuable asset. In fact, fibromyalgia guidelines explicitly recommend that most patients managed in primary care, with specialty referral reserved for refractory cases. From your perspective, from your respective specialties, what role do you think the PCP should play versus the specialists in managing complex conditions?
So, main, referral source, I would say, to me as a subspecialist is primary care. Primary care is so important in helping to, flush out, okay, who needs this subspecialist? I do think that, complex chronic conditions can sometimes overwhelm the primary care space. So these patients take a long time. They take a lot of our energy in dealing with their multifaceted issues. So I see a lot of complex chronic conditions. The most common one that I see is chronic migraine. And I don't like to think of chronic migraine as living in a bubble. There's so many associated symptoms, comorbid conditions. Again, we were talking a little bit earlier about how I tend to see Venn diagrams of different diagnoses. One common one that I see is migraine, POTS, hypermobility. They tend to go hand in hand. They tend to be very multi-system affecting and really, can impact somebody's life, to the point where, I've had patients come to me and say, I feel disabled. I'm looking to get disability for all of these conditions compounding and ruining, my flow of things. So, in a way, I feel like my role as a subspecialist is helpful because I can actually take the time with patients. I have a little bit more of the luxury of time, I think, in that, my new patient visits are 45 minutes, my follow-ups, 20 minutes. But I like to give folks as long as they need to make sure that all of their concerns are addressed and their questions are answered. So in that piece, I do think it's helpful to have a subspecialist. And I find it very hard to say, okay, I'm just going to treat this one piece without looking at everything else. Because, with a condition like chronic migraine, I think we'll get into this a little bit later as well. We're looking primarily at lifestyle. How is your sleep playing a role? How are your meals playing a role? Are you drinking enough water? How is the stress level? How is the mood? Exercise. So it's hard to say, okay, I'm just going to look at this one condition and not address everything else.
So I'm thinking some thoughts related to complex medical conditions. Obviously we see pregnant women who have complex medical conditions, and absolutely I need the primary, but also the subspecialist, the specialist. And it's wonderful if they already have those people that I can contact. For women that are not, for more GYN patients, absolutely very important. And this comes up mostly when we're talking about periods, bleeding, hormones, all that sort of thing. And so So I do have to find out what their comorbidities are, especially cardiovascular, neurologic, that sort of thing. So, yeah, I think having a primary and knowing that there's somebody that knows this person. That being said, some people like, no, I don't have a primary, and it's because they haven't been in the last 13 months, but they actually do have a primary that they've seen before. So there's that concept of people not really understanding what a primary does and how important their primary is. Oh, well, you've seen this person, or at least at that office, and trying to encourage that. You actually do have a primary. So I don't know about you guys, but for me, if I haven't seen somebody for 3 years, she's a new patient.
Yep.
It's the same thing. Yeah. Okay. So, so maybe that's part of it. If they haven't been seen for 3 years, 4 years, which is not uncommon with young, relatively healthy women. So, it's, yes, it is vital to help coordinate everything. Absolutely.
As a PCP, I appreciate your responses. Just value my career. Okay, next questions are about pregnancy and parental leave and career. Nearly 3/4 of physician mothers report that their leave time was insufficient, and many face discrimination upon return to work. From the OBGYN perspective, what does the evidence say about what postpartum women actually need, and how does that compare to what physician mothers typically get? And from the neurology perspective, what neurological or cognitive changes in the peripartum are appreciated?
So I will jump in here. I mean, what new mom doesn't think her time away from work is insufficient? I mean, there's just so much to do in every aspect of life, and you're dealing with, if you're a breastfeeding mom or pumping, hormone changes, just overall life changes, plus work. Right now, in OBGYN, it's 12 weeks and ACOG is trying to label that as the 4th phase of pregnancy, or stage, maybe it's stage, so that we take that into account. But is 12 weeks enough? No. I mean, that's just kind of getting started. So it used to be postpartum time was 6 weeks, maybe 8 weeks, probably 8 weeks for C-sections. Now it's 12 weeks, but even that it just kind of starts to address the tip of the iceberg. And there's so much more involved with women trying to coordinate all the aspects of their lives. But it's a start.
Yeah, I think that a lot of changes occur in this, peripartum period. Obviously you've just brought a new human into the world, or you're getting ready to deliver. One thing that I always counsel my patients on, regardless of, their underlying neurological conditions, are life is going to change. And if you already have, an irritable brain because of migraine, or a brain that, has the predisposition for seizures, the added stress, the sleep deprivation, that's going to lower, your threshold for, your underlying disease to rear its ugly head. So, one thing that I do counsel my mothers on is making sure that they get a solid 4-hour block of sleep if possible. They work with, partner, family. That 4-hour block of sleep is, essential for your brain. That's the minimum that I ask for. If you can get more sleep, great. But 4 hours altogether. I think also one thing that I tend to see a lot in the community is physicians are a little bit afraid of pregnant women. I don't know.
Oh, absolutely.
If you corroborate, but I see it a lot that women will continue to have their medical issues. Fortunately, in the case of chronic migraine, things typically get better. Our bodies love that high estrogen state that's very protective against migraine. So normally, migraine actually improves in pregnancy. However, in an unlucky percentage of folks, it does not. It gets worse in some cases, and that's usually, why they end up in my clinic. And there are, some things that we can do with caution, and usually working very closely with our OB colleagues to make sure, if we're starting meds, the baby is gaining weight appropriately. Do any meds need to be decreased or come off in that peripartum period to minimize risk for bleeding and whatnot? So, I do think in many different ways it does take a village.
What do you all have to say about cognitive changes in that period too, knowing that a lot of residents say are working 80-hour work weeks, if they're lucky, and then going back to work early before that sleep deprivation is over, and taking care of patients.
Pregnancy brain is a real thing. Can I explain it? No. Poor sleep is part of it. Getting up frequently while you're pregnant to empty your bladder, to change position. There's a lot of things that go into the fatigue and poor sleep. There's good information now on some medications that we used to like, no, you don't ever put a woman on that when she's pregnant. So there's that is being relaxed because we do have more data, longer term data on medication. So there's some good things. There's of course a lot of alternative things that women bring in. And I don't know. Let me look that up and I'll send you a message through the portal. So there's that part of it as far as all the alternative and complementary things people want to try. That makes it harder as far as medications and such. But yeah, it's a real thing, pregnancy brain.
Yeah, I wish I had a better explanation from a neurology standpoint, but I do not.
Personal experience.
Yeah.
Pregnant physicians often maintain high work intensity late into pregnancy and take short parental leaves, partly out of concern for burdening colleagues. So how should we as a medical community help normalize parental leave rather than treating it as minimized?
Yeah, this I actually saw a lot during training. I remember, one of my attendings, very, very pregnant, was having some sort of cardiac issue where she needed to take frequent breaks sitting down while we were doing rounds. Her colleagues helped and said, okay, any, consults out of this range, we'll go ahead and take. You can take any consults that are closer to the workroom. But at the same time, I don't know how right that was. She was still there. She still wanted to work. And we all just had to have the understanding, okay, rounds are going to take a little bit longer and we're going to be a little bit closer. I also saw it a lot in training, when colleagues would leave, there was this kind of sense of, oh no, now we got to pick up more shifts.
Did you say shifts?
Yes, shifts.
Oh, I thought I heard another word. Oh.
I wonder too if some of that could be built in a little bit better. I work in a very young practice. We've got a number of docs who are starting their families. And overall, I think we've got a good system in place where, we'll cover each other's inboxes. If we have procedures like Botox, no brainer, we'll get them in, keep folks on schedule. But yeah, overall, in keeping with some of those kind of old-fashioned thoughts, oh, you must push through. I think that, we can do better and plan for it a little bit better.
I agree with leadership. I think now that there are more women in leadership in medicine, addressing that perhaps starting at 36 weeks or 34 weeks, just saying this is what you will do and you will not do this, and telling pregnant women what they should or shouldn't do, because I think physicians, but also other women in the workforce, they don't want to be seen as the slacker. And I can't tell you how often I tell people, everything's going to be fine without you. Everything, it's going to be all right. And they will find someone to fill your shifts and to do that work. It really is going to be okay. And women need to hear that. And I think probably leadership, my group right now, none of us are of childbearing age. Well, depends on define that. But we are not having children now. None of my colleagues right now in my group. So we've not had to address that. But I remember assisting with the C-section for a previa a week before I delivered, and that was not good because I knew that my brain was done. Oh, that was post-call. Yeah. So now that I've had that experience, yeah, there's a time, and it depends on what the pregnancy complications are, that sort of thing, where your brain doesn't work as well, and you probably should not be doing some of those sort of things. So I think, leadership, because I think there's pregnant women want to step up and want to be there for their colleagues and don't want to be seen as the slacker. So I think that's where leadership can really step in, and this is how it's going to be.
And maybe giving them the benefit of the doubt. I've been in situations before where I was struggling third trimester, right? And my supervisor was overheard in the hallway saying, well, pregnancy is a condition, not a disease. She can figure this out, believing the patient when they're having a hard time, I think goes a long way, especially if there's like a track record of having a high achieving professional. That's hard. A lot of subjective stuff too.
Yeah, I mean, it is a condition, not a disease, although first trimester women would think differently. But recognizing that there are phases to the pregnancy when this may not be the right thing to do at this point in time.
There might be other conditions in addition to pregnancy.
Right. Right. And like you were saying, like cardiovascular things.
I want to give the audience a chance to ask questions. We've had a couple of questions about the physician as patient, and then about pregnancy, parental leave, and career. Does anyone in the audience have questions along those lines? Pop quiz time. Or anything else like that? Okay. And let's talk about sex and gender differences in disease. A 2026 position paper recommends that clinicians consider sex-specific risk factors, the role of hormones across the lifespan, and personalized treatment approaches based on gender across neurological diseases. Besides migraine, what are the most clinically important sex differences in neurology that generalists in this audience should know about? For example, in stroke, MS, or epilepsy management during the reproductive years.
So the overall, so I'm going to start with migraine. So the overall kind of life cycle of a woman, we tend to see diseases like migraine pop up in the area around menarche. Then we tend to see some fluctuation throughout time, and typically things get better after menopause. However, there are some cases where women do not get better after menopause, and they actually take a turn for the worse. Interestingly, we see that that is very highly associated with migraine without aura and with aura. Other examples for this, specifically with menopause, I find that it's a really interesting turning point in a lot of these diseases. So, for example, with stroke, stroke risk does go up after menopause. Estrogen in particular is very neuroprotective. So once we, estrogen levels decrease, stroke risk goes up in addition to some of the other, vascular risk factors. We're more likely to develop hypertension and high cholesterol. MS is another interesting neurological disease where we find that, with menopause, again, the disease can either take a turn for the improvement or things can get worse. Why that happens in some people versus others is poorly understood. And then epilepsy, across time, I find that epilepsy tends to be fairly stable. We tend to see different causes for epilepsy across the lifespan. As we're younger, it tends to be more genetic, idiopathic. In older adults, we tend to see it more associated with a secondary cause, like structural abnormalities, prior strokes, etc. Management of epilepsy throughout a woman's lifetime, I find is most variable during, again, the reproductive years. So there are certain medications that can lower efficacy of birth control and vice versa. So that's important as we're talking about managing seizures, things that we want to keep in mind throughout pregnancy. We work closely with OB to make sure that levels maintain stable as, blood volume increases. So these are all things that, we're thinking about across the woman's lifespan.
Cassidy, anything to add?
Not really, because I think I was going to go into it more in question 6 with cardiovascular disease.
You can go.
Okay, so, it's before this, I spent a number of hours just reviewing papers, seminal papers in my OBGYN literature regarding hormones and cardiovascular disease, stroke, that sort of thing. Because I thought, oh my gosh, these guys are going to expect me to quote papers and years and all that sort of thing. But since we're limited on time, endogenous estrogen, we all know endogenous estrogen is protective, cardiovascularly protective, as in women don't develop cardiovascular disease until 10 or 15 years later than men as a rule. So clearly estrogen plays a role. All of the stuff over the last 10, 20 years about hormone therapy, hormone replacement therapy, the Women's Health Initiative, the HERS study, all that sort of thing, controversy about hormones and women trying all kinds of other options, other complementary alternative options that don't really have much data, but a lot of social media presence. And now I think everybody has seen that hormone therapy is coming back in vogue and different, very different from what was in the 80s and 90s now compared to then. So there's so much. Like when I have a woman come into the office and she wants to talk about hormones, of course, in addition to her annual exam, which is a tough situation that we're put in, I tell people there's so much to talk about. I just hop around about the different things and let them know it's very complicated. Please schedule a follow-up. We get it started. Let's try this. And giving women options, talking to them about what they've tried in the past, what hasn't worked, what their friends are all telling them, what the hormone doc in a box is telling them about pellets, what their friends are telling them about pellets. It's a huge topic, and it cannot be done in our 15 minutes allotted time. So it requires multiple visits, multiple follow-ups. Thankfully, as far as going back to the seizure or migraine stuff, there's a lot of contraception options that don't involve birth control pills. But when I say birth control, people automatically think pills. So I have stopped using that. What do you use for pregnancy prevention is my new phrase, because there's a lot of options up there that won't interfere with epilepsy, migraine management.
Have you tailored this other question? How should the well woman visit evolve to better capture lifetime cardiovascular and metabolic risk? And what should generalists be doing differently? Do you see that as part of your role in a 15-minute well woman exam?
Yes, and I've always seen that as part of my role. I mean, that's how I was trained in residency. This has been going on for 20 years. Does that mean all of my colleagues do that? No, there's a lot of, oh, you're here for your PAP and you're done. No, I've always, at least the last 20 years, looked at it more as a well woman exam. And so stressing that with patients of, because now PAP smear frequency has changed and guidelines. And so now it really is more of a well woman. So it's spending time talking, and we talk about that a little bit later about how much longer appointments are for female physicians than men, because we do delve into those family, psychosocial, life stage issues. So it's much more complicated. And so having a OBGYN that you see over time, oh my gosh, we love that. And knowing what their pregnancies were like, or at least some of them, what they dealt with during pregnancies, all that sort of thing is huge. I'll end there.
So menopause and perimenopause affect virtually every organ system. Yet surveys show that most physicians, including OBGYN and internists, report receiving little formal training in menopause management. Meanwhile, the neurological dimensions of the menopausal transition, cognitive changes, sleep disruption, mood disorders, shifting migraine patterns are increasingly recognized, but often undertreated. From each of your perspectives, what do you think we are still learning about menopause?
Well, I basically said it the last question. There's just a lot that has changed over the last 5 or 10 years. And so keeping up with all of that is a lot. I think with menopause, perimenopause, it's individualization. There is no one thing that fits everyone. And part of the reason, Natalie just walked out, but part of the reason I said, yes, I will be on this panel is I've seen some scary stuff come out of, from PAs, not so much nurse practitioners, but PAs on what they're doing for patients. And that caused me to go like, oh my gosh, we OBGYNs need to be out there talking more about all the options, all the things that play into why we choose this option versus that option for people. To say it more succinctly, transdermal estrogen. It's safer for cardiovascular health. It's safer for metabolic issues. It's safer brain-wise. The KEEP study, which I just realized was 25 years old now, talks about how it's so much better for brain health, cognitive benefits, sleep, and what that translates into. And, we can't say that hormone therapy, estrogen therapy prevents cardiovascular disease, but it definitely has cardiovascular benefits and neurologic benefits. We can't say it prevents dementia. I tell people we need 30 more years before we get that long-term data. So there's a whole lot of information. So are we not training people very well, formal training? It's just been changing so much that it's really hard to keep up with that. So I think we OBGYNs need to play a role in that, in helping with that training. Honestly, I prefer to do that more with my individual patient, but it's individualizing things and looking at their risk factors and their symptoms. and not just throwing oral hormone therapy at everyone who says they have poor sleep, because it could be something else, including cardiovascular. There's just so many other issues.
Absolutely. Yeah, and I think that's a big role that, or not so much of a role, but that's a big question that I have for a lot of my patients too. Okay, what is happening with your sleep? Are you waking up at 4 to 5 o'clock in the morning each night with ruminating thoughts? Are you having, restless legs that are keeping you up? Are you having neuropathic pain? What's actually happening here? Can we attribute all of it to the hormonal changes that you have, or is there something else going on? I look for a lot of low-hanging fruit in my clinic, is what I like to call it. Things like vitamin deficiencies, thyroid issues, anxiety, depression, these underlying treatable, modifiable risk factors for any of these disruptions. Because I find that there's a lot of different things that can make somebody sleepy. Doing my training out in Ohio, I saw so much vitamin D deficiency. I thought, okay, I'm going to move back home to Colorado. It's sunny 300 days of the year. I'm never going to see vitamin D deficiency ever again. Wrong. I see so much of it. And that is a huge a huge problem, I think, just with our society in general. We spend so much time indoors and not getting outside, and we're using sunscreen, which is great. We should keep using sunscreen, but we do need a little extra vitamin D. It can really lead to significant fatigue, and then other vitamin deficiencies. Some people just absorb B12 better than others. I don't have a great explanation for that. I've met a lot of folks with non-GI diseases, normal diets. They just have low B12, and they feel really crummy. Same with iron. I feel like iron is a huge one. I find that most of my young female patients are iron deficient. If anybody has the complaint of fatigue, very low threshold, get an iron panel plus ferritin.
Poor concentration, all of that.
Can disrupt the sleep as well. We think that, low iron has an association with chronic migraine as well. So, these, like I said, all low-hanging fruit, which can be helpful. You kind of have to look at the big picture. I've been getting a lot of questions, though, about, hormone replacement therapy. Many of my menopausal women will say, when should I start looking into it? What's your opinion on when they should start looking into replacement?
More around the perimenopause and shortly after. So one of my long-term patients at age 63 asked me if she should start on hormones. She had never chosen to before then. Oh, menopause was easy. And I said, no, because she's got some significant cardiovascular issues that we know that if you're starting hormones, estrogen, more than 10 years past the final period, you're right on the edge of cardiovascular disease worsening. So there really is I'm blanking on the word right now, but there's a time frame when it's helpful in the early perimenopausal years. So perimenopausal and early postmenopausal years. And once you get 10 years past menopause, then your cardiovascular disease risks start going up. So, there's definitely an age. There's a threshold, and so you have to. That's where again you have to know what their other comorbidities are, their family history, their lipid panel when it comes to recommending hormones or recommending against hormones.
I think those of us who trained in the wake of the Women's Health Initiative have not been encouraged in our training to even consider menopausal hormone treatment. And so if there was one thing that you could tell generalists about, this is how I want you to think about prescribing these medications or not prescribing or encouraging them or referring them, what would you say?
I do 4 things.
Please.
Early in the menopause, less than 10 years, transdermal estrogen, natural micronized progesterone. I guess just knowing there's so many different options.
What about contraindications?
History of PE, history of DVTs,
Stroke.
stroke, yeah. I don't consider cigarette smoking to be a contraindication. And honestly, there's so many people that are no longer smoking. They're all vaping constantly all day. We have no data on that. Age in their 70s. So there are women coming in asking about hormones when they're in their 70s. And I am telling people in their late 60s, early 70s, we need to come up with a plan for transitioning you off hormones, off estrogen, because stroke increases with age. And so we need to have a plan when you're in your early 70s. I would like you off of systemic, and I'm talking about systemic estrogen, in your early 70s. And that can be a little bit of a battle for some women who have been on them since their hysterectomy at age 41. So, yeah.
What about breast cancer, though, doctor?
Yeah, the whole breast cancer thing was really overblown. And there are some people that speak much more passionately about that overblown, how that was overblown. The Women's Health Initiative is the study that everybody quotes when it comes to that. It really was statistically significant, but very small increased risk. And it was in the Prem-Pro arm, not in the Premarin arm. And I do this to people. There was the Prem-Pro, and then there's the Premarin, and nobody heard about the Premarin arm. I don't even know if Premarin's available anymore. So that piece was overblown. Probably people think I'm not telling the truth when I say that in the Premarin arm, they are still studying that group of women, and there is no increased risk in breast cancer. In fact, there's a decreased risk of breast cancer long term. And the other piece with Women's Health Initiative is the placebo group contained a significant number of women who were previously on hormone therapy that were taken off their hormones, washout period, and then started on hormone therapy. So it was smaller than expected amount of breast cancer in a significant number of those women that led to the early release to the media of the information instead of to the medical community. So yeah, I would say probably the last 5 to 10 years, there's, at least in our field, there's much more of a hormones are safe type of thing. But we do have to deal with the concept of people still believe what they read on the internet. Now, the women who are really symptomatic, they are less likely to believe that because they're like, help me. There can be 2 things that are true, and you can hold both of them. One is that menopause is normal and natural, and the other is there's benefits from hormone therapy, estrogen therapy, and that's where I have to feel that out. Where is this woman? What is her family history? What are her symptoms? It's complicated, which is why these appointments are not 15 minutes. Does that answer your question?
Absolutely. Okay, last transition regarding burnout, mental health, and the culture of medicine. Female physicians have a 20 to 60% higher prevalence of burnout than male colleagues, driven in part by sexual harassment, work-family conflict, pay disparities, and the second shift home. The COVID-19 pandemic made this starkly visible, with physician mothers roughly 30 times more likely than physician fathers to be the primary child care provider. What has changed since the pandemic, and what hasn't? This is probably a personal experience question rather than a what did the studies say question.
Yes.
So, yeah, so I was in training at onset of COVID. One thing that I noticed, kind of before and after, there was this thought, you can't take any time off if you're sick. I saw a lot of physicians push through. I once talked to a female surgeon who told me that she was, she had the flu. She still went to work. No reason for nobody else to not come to work. It's just the flu. Rigors, vomiting, just the flu. And what I noticed, following COVID-19 is we tend to take that a little bit more seriously, in that, well, maybe you should take some time and not, be operating on somebody if you're very, very sick, or, not show up to clinic if you're having trouble making it through an appointment. That was one of the big differences that I saw, that it became a little bit more acceptable.
And perhaps part of that is recognizing that you coming to work and pushing through it is putting your older colleagues at risk.
Yep.
And so then it became a little bit more accepted. Like, I need to do this for everyone's sake, and older patients or patients with comorbidities. So I would also say, I think the COVID pandemic led to more women physicians recognizing that you can't be superwoman. And so what can you do, and what do you need to give to someone else?
Well said. Very well said.
We know that women physicians spend more time on average, 2 minutes per patient visit, and are more likely to explore psychosocial issues. Is this a strength that medicine should protect, or a contributor to burnout that needs to be managed, or both? And how do each of you handle this tension in your own practice? And I would add, how has it changed throughout different phases of what else you have going on in life?
Mm-hmm. Yeah, I spend a lot of time on psychosocial issues in my clinic, because, I do want to explore the sleep and the stress. And, I don't find it as much of a, burden on myself, because, I find it very important. However, I do find that, sometimes you hear things and you need to compartmentalize a little bit. One thing that I don't like to do is I don't like to take what I've heard in clinic home with me, because I would let it weigh on me otherwise. It's interesting. Yeah, people will tell you a lot if you ask, a lot more than you may want to hear. But overall, I think for my clinic, I do find it's a strength, and I find that it helps with that patient-physician relationship. It helps kind of build trust, and I get a better understanding of what they're dealing with, where they're coming from. And I think that, patients really appreciate that. I want to get to know them as a whole person. But very important to compartmentalize, and make sure that we're not opening, a whole new can of worms. I have a very low threshold to discuss behavioral health referrals in particular. If I get the sense of, it seems like, you haven't talked to anybody else about this. Would you be interested in getting established? That's a good, segue. Overall, I do spend a lot of time on it, but I find it is a strength for me.
And I would say it's a strength for me also. Again, I would just echo what Lisa said. It helps me to build the relationships to better counsel, manage things. I will say that some days I do this better than others. So there are some days I'm really on my A game. I'm not fatigued. I'm not dealing with something that happened recently that's affecting everything. So some days are better than others. Some days, like, really, how did I get more of this type of patient all in the same morning. And then other mornings are just easy peasy. You can't control that. But compartmentalizing, yes, leaving it at work to an extent. I will say I have a wonderfully supportive husband who lets me talk out things. And so whatever that is, there are some things you just have to, at least as a woman, unload and talk through. So yeah, I think it's a strength. Has it been a weakness at times? Yes. Those are the days that I don't manage it as well. So, and then recognizing there are days that I can't fix that problem. And referring to behavioral health, which that's a great thing right now. There are so many more behavioral health therapists and so many people doing virtual. I think they were virtual before medicine was virtual. And most women that I take care of, they're okay with that. Because they're comfortable with the whole virtual thing. So that's a blessing.
It's gotten a lot more convenient, certainly, scheduling wise too, I think.
I'm going to give the audience another opportunity with those burning questions.
I have a thought. You were talking about, but I wonder if there's backside of it is when we'll come ever. Just wondered in that study that you told me.
I know that there have been studies that address the expectation that female physicians spend more time. Yes. So the question basically, if there is an expectation, or I'm sorry, if the study addressed why, what's the root cause?
Patient.
So the question whether or not the study suggested the root cause, basically, if there's a difference in the relationship. I don't think I can speak to that with this study in particular, but I don't know if you all have experience with that. That's what I've read, is that there's an expectation, and that if you don't, it shows up probably in your, patient satisfaction surveys. I definitely know that I have colleagues in primary care that can see 25 a day, no big deal. And there's no way that I can handle that because people are in tears all day long. I don't know. What do you all see in your practices?
So there's a mandate is the word I'm going to use for doing PHQ-9 or Edinburgh multiple times, multiple touches. So, I mean, how can I not talk about it when it's 18? And so, yeah, so that caring part of me, if that's an 18, then I know that's a significant issue. We need to talk about it. So, because the other stuff, yeah, I can listen to the dop tones, measure the belly, get them scheduled for appointments, but that's the elephant in the room that must be discussed. So I think that plays a role in why maybe do we women pay more attention to the psychosocial issues as for women? I'm going to say yes, probably, because we can't compartmentalize as well. We're juggling multiple things. So recognizing that these things I don't need to worry about as much, and this one I do. I don't know if that's an answer or not.
Yeah, it kind of has me thinking about like paternalistic medicine. Do we offer some sort of maternalistic medicine? That's a good question. I I would say in my, personality, that my, the way that I interact with patients is, very supportive, empathetic. That might just be me. Who's to say, a male colleague doesn't do the same? Is there any significant difference between us two? Hard to say. I wouldn't think so. I would hope not. But
That would be very difficult to study.
yeah, that would be very difficult to study.
So you have surrogate markers like 2 more minutes per patient visit. That should handle it, right? What else?
Question.
Well, I will turn it to practical takeaways. If you could change one thing about how the healthcare system treats women, both as patients and as physicians, what would it be?
So I think going back to my mantra of, I can't have it all. I think part of what I would change, maybe a little bit more internal, but, you should have, what you deserve. And that's, a healthy life, practice where you feel fulfilled, time with family. I think that releasing some expectations too, that all means, what you should have and be happy, don't necessarily equate the same thing, and it's okay to say no sometimes. And, decide what's important to you moving forward. And to just give ourselves that grace. I would change.
And I think that's true for men as well. So this question, I've been thinking about it ever since Natalie handed this, how it treats women. I would say how it treats physicians.
Yeah.
I remember in med school, the lunch break, there was a talk, and it happened to be by an OBGYN, and she said, you can have whatever OBGYN practice you want. And she gave some examples. You could focus on incontinence. You could focus on now minimally invasive gynecology. There's all these options. You need to choose what's important to you. And I would say that's true for men too, because I think there's men that think they're supermen, and then they crash just like super women crash. So I feel like maybe the right answer to this is that women shouldn't be compared to men, but who else would you compare them to? But I think looking at there's many different ways to do things and many different types of practice. Just like you mentioned, you're a headache specialist. There's just so many options, and so I feel like we're making really pretty good strides in this whole arena of changing the healthcare system to be more real and allow family and other interest.
Dr. Cassidy, Dr. Moore, thank you for sharing your expertise with us today.
Thank you for studying.
Yeah, absolutely.